Before I begin, let me thank the organizers of this 49th National Conference of IAPSM and 23rd Joint Conference of Maharashtra chapters of IAPSM and IPHA at Government Medical College, Nagpur, for giving me this opportunity to deliver prestigious Padmashree Dr. D.N. Pai Oration of Maharashtra chapter of IAPSM. It is a very overwhelming feeling and a very proud feeling to present this oration on the online platform. It is a matter of great pride for me to get this opportunity to deliver the oration on the name of late Padmashree Dr. D.N. Pai, who was the first professor and head of Department of Community Medicine at St. G.S. Medical College and KM Hospital. Um, Today, I am the fifth professor and head of the same department. Dr. D.N. Pai was like a grandfather figure to my generation faculties in community medicine. I had an opportunity to interact with him for the first time during my PG days for this support in data collection for my MD dissertation work. I was a PG student of LTMMC and Sion Hospital then, and I had visited the Institute for Senior Citizens at Neral Karza, where Dr. D.N. Pai was present, and I could interact with him for the first time. I only remember that he appreciated my decision to pursue the career in PSM and gave me the words of wisdom that PSM is a practice and it is not a full-time job of teaching in a medical college. Of course, I had no insight in the subject this way then. When I gave feedback to my guide Dr. P.S.N. Reddy, about to whom I met at Neral Karza at the institute, he told me that the person with whom I had interacted was Dr. T.N. Pai, and he was the ex-professor and head of PSM at GS Medical College and KM Hospital, and was considered as a stalwart in our subject and a very reputed and highly respected personality in the faculties, amongst the faculties of community medicine. Dr. Pai was a pioneer in establishing then the Department of Preventive and Social Medicine at CHJS Medical College and KM Hospital in the year 1959. He was heading the department till 1982. His footprints are still felt and respected at the department level even today. Today, I consider myself very lucky to head the same department, which was headed by Dr. D.N. Pai for almost 23 years. He was the first hardcore public health expert who joined medical college and excelled on both sides and proved himself to be the excellent teacher in community medicine, having very good linkages with public health sectors then. He is still remembered for his exemplary work in family planning. My topic, micro-level reforms to enrich public health teaching expertise amongst faculties of community medicine. Why did I choose this particular topic? Micro-level reforms to enrich public health teaching expertise amongst faculties of community medicine. Now we know that most of us are teachers at medical college, and for the medical education, we are the frontline workers, and hence what is expected at this micro level matters a lot for students as well as for those going to become the teachers in future. Even though we are professing the subject of public health for healthcare services, I have always felt some gaps or lacunas in our expertise to teach the public health with relevant live experience gained through the independent practical work in the field. Our PG students are expected to learn principles and practice of public health in medical college from the faculties of community medicine. Hence, medical teachers are expected to have public health expertise and skills to fulfill their role as teachers of public health experts. For clinicians, there are hospitals, OPDs, and wards to gain practical skills. What about us? For from where we are going to get the practical experiences and skills in public health. We know that public health experts undergo postgraduate training in community medicine at the medical colleges. However, when they work in public sector, usually they get dissociated with the medical college or the departments of community medicine. Junior faculties working in Department of Community Medicine at medical college level may not be aware about the applications of the subject knowledge in public health sector, and similarly those who work in public sector may not be clear about how their experiences in the field can be incorporated in teaching curriculum to enrich the PG teachers and students and enhance the importance of the subject and improve the visibility of the subject at medical college level and the medical profession in general. Lot of deliberation discussions have taken place in this respect at macro level, at the level of Minister of Health and Family Welfare and Medical Education formulation level. But there are issues in percolating the actions at micro level where the real change is required. We must believe in think globally and act locally philosophy. In medical profession, the importance of your work is usually understood on the basis of how much worth you are to the health of the individuals as well as the health of the general public. On these parameters, community medicine experts are seen at lower level at the medical college, and public health functionaries are considered as administrators of public health department without understanding their professional responsibility as community physician. It is hard to accept that the PG students in community medicine understand the true importance of the subject skills and its applicability after obtaining PG degrees. Postgraduate students in clinical subjects obtain knowledge and skills to the level of empowerment to manage the practice in the open world. This is limited in case of community medicine. Medical college faculties undergo a lot of trainings from public health sector with initiation of any new program or management practices, but there is hardly any utilization of this knowledge to the public sector. All faculties in community medicine and public health experts should introspect this paradigm with due concern to find out strategies to fulfill the gaps on either side. There is a scope to initiate or facilitate micro-level reforms to enrich our medical faculties in their public health expertise and practice, beneficial to the upcoming PG students and to the public sector. When I when I introspect in the past, my experiences related to teaching the subject to PG students makes me understand the limitations in building the essential skills amongst the PG students. Like, will he be able to plan intervention program to reduce malnutrition? Will he be able to evaluate functioning of primary health center or sub center independently? Will he/she be able to evaluate implementation of any national health program at district hospital or CSC level? Investigation of an epidemic independently? Program or elimination of scabies in 20 villages together? Will he be able to mobilize the community participation for outreach activities? I always introspect whether the indicators of health are different in two primary health centers, one affiliated to medical college and one not affiliated to medical college. Same thing holds whether development of referral linkages in two primary health centers, one affiliated to medical college and one not affiliated to medical college. Community medicine, we believe in the phrase good health is true wealth. How we came into existence. Concept of starting separate department of PSM at medical colleges was mooted in the first World Medical Education Conference, which was held in London in the year 1953, and subsequently at the All India Conference of Medical Education held in the year 1955. These departments were identified as linked between the tertiary care hospitals and public health services. The primary role comprises of family medicine and public health. In the UK, they were called as the practitioners of public health medicine. In 1974, Dr. J.B. Srivastava committee advocated starting the urban field practice areas for medical college. Each medical college ideally should identify a separate urban field practice areas of their own. Faculties are involved mainly in teaching, but they do not play proactive role in developing working relationship with the healthcare delivery system. Besides teaching experience, scientific publications and research projects, there is no consideration given to the experiences in public health sectors when it comes to consider for next level promotions to the medical faculties. Of course, I remember in the past, the public health officials used to take the lectures to UG and PG medical students which used to be very interesting, being full of practical insights in the subject. What we expect from community medicine faculties? We expect teaching training, of course, teaching the students, healthcare workers, research aspirants, NGO functionaries working in public health, research, operational research, action research, field studies, community trials, etc. Support health services, advocacy for community health demands and utilization of health services, facilitate good governance practices at beneficiary end, and empowerment of community. Now, we all faculties are very clear as far as our role in teaching, training, and research is considered. But what about the other domains? When it comes to support the health services, what is expected? We are expected to perform in organizing the services activities at different levels as per the stipulated protocol, monitor and supervise various field level activities undertaken with the prime focus to improve the health indicators, identify training needs and hands-on training to the healthcare workers, support for documentation, concurrent evaluation of ongoing activities, receiving feedback from beneficiaries, institute good governance practices in all functions rendered while providing services to the patients, demonstrate the accountability wherever possible, and publish good case studies, success stories, learning lessons, in-depth reviews, and research papers. Now, on the domain of advocacy for community health demands and utilization of health services, our role is to develop networking with community stakeholders, community needs assessment to understand what are the true needs of the community, identify the problems of vulnerable groups which are present in the community or in the area, understand health seeking behavior of the people to find out what really needs to be done to improve their utilization of the services, know day-to-day functioning of each health infrastructure unit, discuss the issues in utilization of health services, know level of satisfaction amongst users of services, and explore areas for improvement on these domains. When it comes to facilitate the good governance practices at beneficiary level, we also have to play a very crucial role. First, to provide the entire range of stipulated services to the beneficiaries, we should be on the lookout whether entire range of services are provided from that particular peripheral health point or no. Availability of medical officers at the OPD and emergency cases, ensure home visits by the paramedical staff as per the norms, emphasis on monitoring and supervision of the services under all the activities. We need to develop a good collaboration with ICDS functionaries. Quality of data generation and record keeping also should be our priority. We must focus on extending the benefits of all national health programs to the desired beneficiaries. Accountability to the system and beneficiaries must be exhibited in all the activities, and it has to be felt in that way. And we should be very careful in observance of dignity of the patients whenever we happen to interact with the patients. Our job is also to empower the community. On this domain, lot many things can be done by the faculties of community medicines. Functioning of Rogi Kalyan Samiti or Sallagar Samitis which are existing at community health centers, rural hospitals or primary health center level, whether they are functioning and whether they are rendering their role or services and whether they are providing the voice of to the demands from the people. It is equally important to observe the citizens charter. We need to listen to the stakeholders to understand their demands and to listen to the voices of the people. Networking with CBOs and NGOs will get us to develop the community ownership to all the healthcare related activities. We need to observe the functioning of grievance handling and conflict resolutions from time to time. We should respect the community intelligence which can be harnessed for the betterment of the community or for the community well-being and empowerment. There is a scope to promote good cultural practices which are beneficial. Support for community participation and involvement is very much essential to sustain the ownership for a longer period of time. We need to organize the frequent health awareness campaigns for the people. and we need to create empowered group to support health services. Now, when we talk on the public health front, you must have understood in the previous slides that as far as teaching and training and research is concerned, we are clear. But for other domains, uh, unless and until we develop the appropriate skills and expertise, we will find ourselves very difficult. Rather, we are finding ourselves very difficult to empower our students, PG students, to understand and practice the public health activities. When it comes to public health, we know that the Lancet Commission in the year 2010 and 2018 has advocated, recommended networking and partnerships for improving public health education. Regional meeting on teaching of public health in medical schools at Bangkok, Thailand on 8th to 10th December 2009 was an advocacy meeting to raise the awareness of faculties, administrators, and stakeholders on the teaching of public health in medical school and identify the areas for strengthening. The meeting focused on the situation of the teaching of public health in medical schools in Southeast Asia and globally. Medical doctors would appreciate and value public health if the teaching of public health in undergraduate medical schools is interesting, relevant, and effective. Robust health system based on primary health care and public health interventions are the most effective means to reduce the disease burden. The health workforce need to be properly trained for the same in public health to be more responsive to the entire range of health problems and needs of the community in line with the expectations of National Health Policy 2017 and Sustainable Development Goals. When I say get enriched in public health teaching skills, what it means to us, we should be adequately proficient in public health, be able to work effectively in the multi-sectoral and multidisciplinary environments and effectively adapt to the constant change in health paradigm. Be involved in public health education and research, including training and supervision of field staff. Support the functioning of public health units such as training cells, integrated disease surveillance project units, health management information systems, etc. Get involved in health activities beyond the boundary of medical institutions, that is district hospital, community health centers, primary health centers, maternity homes, dispensaries, public health laboratories, non-government organizations, private practitioners, etc. Remember, from public health teaching point of view, we need to introspect what we see. Are we seeing directly or through somebody? What we are hearing, is there any scope for us to hear directly from the respondent, from the beneficiary? Whether we are reading theoretically and not for practical purpose. What we speak, does it make any sense for the policymakers? What we teach, has it got any practical application? We are writing only for the academic purpose or for community empowerment, research work? Has it got any direct implications for the welfare of the community? And whatever criticism from time to time we make, is it a constructive criticism or otherwise? Now, over the time, public health and medical education have become separated. Medical colleges and public health departments, we expect them to work together for many things like social and behavior change communication, empowerment of individuals and families, and sustainable community development. There is a need to strengthen the teaching of public health to produce what we call it as a five-star doctor. That means the doctor which has these important five qualities: a good care provider, decision maker, communicator, community leader, and team member. Of course, it is important for the teachers to believe in and appraise public health interventions that students could observe and learn from. Always remember that the teacher is the most powerful variable in the educational environment. Teachers' skills, knowledge, attitudes, interest, enthusiasm, all these things matter a lot for our UG and PG students. to pursue the future career in public health. Now, considering the healthcare reform movements and the dynamic changes which we are witnessing at present time, there is a need for teachers to update their knowledge and teaching skills in public health all the time. Okay, we have really learned a lot of lessons from COVID-19 pandemic, which we are witnessing for last 2 years. This pandemic has made it possible to us to understand the scope for preventive services, including immunization. We could understand the scope for screening for preventable diseases, issues in utilization of existing health services. We have understood the level of readiness for handling the pandemics and epidemics at different levels, right from tertiary level institutes to primary level institutes. Scope for sustainable capacity development is also very clearly evident through these experiences. Infrastructure limitations in rural and urban areas are very clearly understood. Scope for improving the functioning of peripheral health institutes is also very clear to you at present times. Scope for social and behavior change communication for adapting the behavior change in long run for practically all the illnesses should be pursued. And the term or the phrase "my family, my responsibility" campaign, which was advocated for addressing the issue of COVID-19 pandemic, it can equally hold true for handling other important public health problems also. National Medical Commission guidelines for competency-based postgraduate training program for MD in community medicine identifies 34, 3 and 12 competencies under cognitive domain, affective and psychomotor domain respectively. It is said very clearly in this document that MD community medicine person should be equipped with the knowledge, skills, competencies in primary, secondary and tertiary care, control and prevention of outbreaks, epidemics, community diagnosis, health needs assessment, epidemiological assessment, research and planning evidence-based health policies and programs. The competencies must cover a wide spectrum of skills: technical, managerial, administrative, organizational skills, applied skills in health information management, software application and soft skills of communication, motivation, decision making, team building, training in scientific communication and medical writing. All these qualities are expected in a candidate who is clearing MD community medicine examinations. The purpose is to create a skilled cadre of medical professionals having expertise in application of principles of public health, community medicine, and applied epidemiology, contributing meaningfully in formulating national health policies and programs with a systems approach for overall human development. Now, this is something which is taken as it is from the document NMC guidelines for competency based postgraduate training directly. And if you really look at all these points, it is very clear that a lot of emphasis is given to develop the skills appropriate to uh, get expertise in public health. Now, this document correctly identifies, this is a table given in this document, NMC documents, okay, which clearly identifies the field postings and work duration. And it is written that the posting at subcenters, primary health centers, under and at RSTCs and USTCs attached to Department of Community Medicine as per MCMO, for which the total duration of 1 year out of total 3 years duration of MD course is stipulated. Besides that, work attachment to gain hands-on skill-based training in public health departments and orientation in health administration and management of various national programs and aspects of public health management at the offices of district health officer, the Directorate of Health Services, Taluka Health Officer, District TB Officer, District Malaria Officer, Child Development Project Officer, Medical Officer of Health of local civic bodies or district health authorities. 1 month of posting is earmarked mainly for these activities. Besides that, 1 mark is also identified, earmarked for short duration postings in various camps, melas, public health emergencies, investigations of epidemics, implementation of NHPs, linen department of hospital, hospital kitchen, hospital record section, central drugstore, medical superintendent office, blood bank, casualty department, CCL, hospital waste management, ART, BCTCs, matron office, HMIs, etc. So totally almost 1 year plus 1 month plus 1 month, 14 months are available with us to get a very good experience in public health and to develop expertise and experiences in public health. Okay. Today we are talking about Indian medical services also. Now, this Indian medical services existed in pre-independent area. Medical services were first set up in Bengal, Madras, and Bombay administrations during 1763. Ronald Ross, who discovered the mode of transmission of malaria parasite, and Charles Donovan, who found the pathogen causing Kala Azar, were both members of the Indian Medical Service. In post-independent area, the Health Survey and Planning Committee, also known as Mudliar Committee, recommended the formation of Central Health Cadre in our country in its report in 1961. An Indian medical service, in line with other civil services such as IS, IPS, IPS, etc., are recommended. A parliamentary committee recently expressed the views in favor of exploring the possibility of service that would bring a major change to the health system of the country. Present COVID-19 pandemic reveals us the importance of health professionals not just in managing the pandemic in health institutions but also at the level of the government. Today, the country needs a new Indian medical service as a cadre of efficient public health managers at the national level. Now, whenever it is going to come into existence, definitely this will provide a well qualified administrators very clear with the medical services domain for supporting the public health services. With these backgrounds, what reforms we are suggesting or we are considering for this purpose? In order to improvise our understanding of public health, in order to improve our experiences and expertise in public health, what is possible at micro level? First of all, the district allocation to medical colleges. We are talking constantly about all these things. We have the medical colleges located in various districts. Now, why one particular district cannot be allocated to one medical college community medicines or collaborative linkages with all district health authorities? A good collaboration, if it can be developed with district health authorities, lot many things can be learned by the PG students, not only PG students, but the faculties in community medicine to get empowered with. It is possible to establish the functional accountability of urban health training centers and rural health training centers with the public health department. Now, what is happening today that we have our existence separately. A lot of activities are performed at these units. Okay. However, there is no direct linkage with the public health department, and whatever services we are providing, whatever activities are we are performing, we have not set an accountability with the public health department, and that is something which keeps us away from getting along with the public health priorities. Is it possible to consider placement of postgraduate students in health services to be supervised by their respective guide up to 6 months with standard program schedule with short assignment? Now, this is something which can be done at the medical college level itself. Now, whatever is the duration of the placements in the RSTCs, USTCs, 6 months of them can be totally earmarked for the placements with the district health authorities or Directorate of Health Services, whatever is feasible, and a short assignments to ensure the compliance on the part of the students and faculties, that they learn and they gain a proper insight into the functioning of public health. Is it possible to place the community medicine specialists in public health services, maybe for a duration for 3 to 5 years? This I do not know whether I can call it as a micro level or macro level, but this needs to be given a thought. We can identify the positions for community medicine specialists in public health department, maybe the public health managers positions which are now recommended at district hospitals or the rural hospitals under IPHS guidelines. They can also be placed at district TB center, HFPTC, disease surveillance units, national health programs, HMIs, public private partnership initiatives, etc. We can place them, or we can entrust them the responsibility which is purely of technical nature rather than giving them some jobs in administrative capacity. We have a scope to adapt the new approaches to ensure compliance on the part of the PG teachers. For example, extra credentials or academic promotions can be considered based on whatever experiences the respective faculty has taken from public health department, whatever collaborative linkages he has developed, what experience he has of directly working with the public health department. It is also possible in a different way, placement of public health experts from Directorate of Health Services side to medical college. This is also very much required. Maybe at least for teaching or training purpose, or maybe for a specified duration of 1 to 3 years or 3 to 5 years, whatever is feasible. Now this will make it possible for our students or our faculties to have a direct interaction with the public health experts and to learn from the live experiences which are likely to be shared along with the theory knowledge. We need to develop the data sharing guidelines between medical college community medicine departments and public health services to promote the health services research. There is a scope for health services research. A lot of data is available with the government or the public sector. However, there are issues in accessing these data by the faculties of community medicine departments of the medical college. We need to identify, or we need to develop this data sharing guideline so that whatever is the ready-made data available, it can be harnessed for the research purpose, and medical college faculties can very well take up this responsibility. Even this also will help them to get proper insight into the functioning of public health department. Professional bodies like IAPSM, IPHA, national, international NGOs can push these agendas at appropriate level. Remember that we are witnessing the COVID-19 pandemic. The lot of importance is already identified for the departments of community medicines who have participated directly or indirectly in this particular pandemic to reduce the transmission, to reduce the disease burden, to reduce the mortality rates, etc. That means an enabling environment is already created to push these agendas at present times. So we definitely should focus on these micro level activities or these micro level reforms which are possible provided some brainstorming workshops are held on the individual points, how this can be made possible. Of course, these reforms are for mutual benefits of community medicine departments as well as for the public health. It is possible improvement in public health teaching skills amongst the faculties through live experiences which they are going to gain if these reforms come into existence. Availability of technical experts in key positions at peripheral levels is possible. Better orientation can be given to postgraduate students who are joining year by year. Better understanding of practical aspects of community medicines to the PG students as well as for junior faculties. Expansion of public health practice area to the medical colleges. And a wide scope, research scope in public health sector if we have proper data sharing guidelines in existence. So what is the final message we want to deliver? We say public health is a practice. Practice requires relevant expertise. Expertise develops out of work experience. Work experience is generated by doing the work. Public health teachers should do the work to get experience, to develop expertise, to become proficient in public health practice. Community medicine faculties are public health teachers. Hence, we all as community medicine faculty should adopt the reforms to be a good public health teachers, to uplift the importance of this subject and contribute substantially to fulfill national health goals. Remember, believe that we must change if things have to look better. These are the references I have gone through to prepare this particular topic and to present the highlights. Thank you very much.